everyone, and welcome to the Nutrition Strategies for Managing Diabetes in Healthcare 2.0 webinar. My name is Jessica Smith, and I'm a Senior Scientist at the Bell Institute of Health and Nutrition at General Mills, and I will be your host for today's webinar. For those of you not familiar with the Bell Institute of Health and Nutrition, we're a team of food and nutrition experts within General Mills whose mission is to be the source of health, nutrition, and wellness expertise that creates value and growth for General Mills. We're happy to bring you this webinar today in partnership with General Mills Food Service. Before we begin today's program, I'd like to cover a few housekeeping matters. First, this webinar is being recorded. Second, the recorded webinar, along with the slides, will be available to you after today's presentation. Third, at the end of today's webinar, we'll have a Q&A period. You may submit questions at any time during the webinar by using the chat feature located in the lower left-hand corner of your screen. And fourth, after the webinar concludes, you'll receive an email with links to the PowerPoint slides, continuing education credits, and a survey link. As a reminder, you must register and log in to the webinar with your individual credentials to receive credits for today's webinar. And now it's my pleasure to introduce today's distinguished presenters. Our first speaker, Maggie Powers, is President of Healthcare and Education at the American Diabetes Association, the nation's largest voluntary health organization leading the fight to stop diabetes. Maggie conducts research and has a clinical practice as a registered dietitian and diabetes educator at the International Diabetes Center at Park Nicollet in Minneapolis. Her research focuses on improving diabetes outcomes, including factors that affect the clinical, psychosocial, and behavioral aspects of diabetes. Our second speaker, Constance Brown-Riggs, is an award-winning registered dietitian and certified diabetes educator. She's the author of several books, including The African American Guide to Living Well with Diabetes and Eating Soulfully and Healthfully with Diabetes. Over the course of her career, Constance has established herself as an expert in nutrition, diabetes, and the cultural issues that impact the health and health care of people of color. She is not only versed in the science of medical nutrition, but also has an active nutrition counseling practice through which she sees hundreds of patients. In today's webinar, Maggie will cover in Part 1 the 4 goals of the American Diabetes Association's nutrition therapy recommendations. In Part 2, Constance will cover stages of change, motivational interviewing, and the AADE self-care behaviors. With that, I will now welcome Maggie Powers. Maggie, over to you.
Thank you, Jessica, and thank you all for dialing into the webinar today. We're delighted to have you and to share our information focusing in on diabetes. And I also want to extend a thanks to the Bell Institute for sponsoring this webinar and finding this topic of value. I am going to start with my first slide, which gives on the left-hand side a little bit of a review of a previous webinar. Some of you may have participated and others may be just jumping into this webinar 2.0 just so that we're all on the same page. So let me just review the two boxes on the left-hand side. I'm highlighting that there's 4 types of diabetes. Sometimes we talk about diabetes as though it's one disease, one medical condition, and there really are 4 distinct types of diabetes. And I think that we need to remember this and not lump everybody in together. There are similarities, but there are lots of differences. The first type is prediabetes, and right now in the U.S. we have about 86 million people with prediabetes. Not all of them know it. We have this condition because there is sound research that was so distinctive in the response that it ended early because the lifestyle arm did so well. NIH said it's unethical not to provide this intervention to everybody, and that's quite remarkable. The intervention regarding lifestyle was focusing on healthy eating, exercising 150 minutes a week, that's about 30 minutes a day, 5 days a week, and also losing 5 to 7%, 5 to 10% of body weight. So it wasn't a drastic weight loss, but a little bit of weight loss, eating healthfully, and having 150 minutes of exercise a week can prevent or delay the development of type 2 diabetes. And so with millions of people in the U.S. Having this condition, we feel that we need to highlight it and know that we can intervene early. The second type is gestational diabetes. Sometimes you'll see it written out as GDM, so it's gestational diabetes mellitus. We don't often use the M, but we'll abbreviate it as GDM, and this is diabetes during pregnancy. So if any of you have ever been pregnant, you may have automatically had a glucose challenge test between the 24th and 28 weeks of pregnancy. That is the time frame when insulin needs increase. Now they increase up until about the 36th week, and so we try to catch gestational diabetes early. We want to control the blood sugars during the pregnancies, and actually the blood sugar target goals are a little lower than if you had type 1 or type 2. We're very aggressive. We're often prescriptive with what we do. We try to work with each individual's food plan, activity, but we aim to control those blood sugars, and so we provide a lot of education, a lot of support. After the pregnancy, the diabetes goes away. We, however, know that if you've had GDM, that tells us that your body is having some difficulty making insulin. So we monitor those women carefully because they're at risk for developing type 2 diabetes. And in fact, where I work at the International Diabetes Center, we have a series of visits, and on our last visit before the pregnancy, we talk about postpartum and how to manage their lifestyle to prevent the type 2 diabetes. That's so important. And then type 1 diabetes, this is the diabetes that has typically been diagnosed when people are young. We've called it juvenile onset diabetes, but it can happen at any age, and these persons have to take insulin. Their pancreas does not make insulin, and so they have to get insulin in their body one way or the other. Right now it's through a needle, either injections or through an insulin pump. Certainly people have worked on inhaled insulin, and it's just not available yet. Right now it has to be through an injection or an insulin pump. Type 2 diabetes starts out usually with nutrition therapy. Pills are added, and then injections are added. And many people, after they've had diabetes for about type 2 diabetes for about 15 years, many of them do require insulin. So it's not the same as type 1, but they're insulin requiring type 2. So hopefully that gives us an overview and kind of sets the stage for some of the other things that I'm going to be talking about during my portion this morning. I also want to highlight that with all types of diabetes, what we're trying to do is distribute the carbohydrate throughout the day, because when you consume carbohydrate, your blood sugar goes up. You need insulin to bring it back down. So depending on what type of diabetes you have, you're either eating the carbohydrate and dosing insulin to match that amount of carbohydrate, or you're working with your own pancreas to make enough insulin. So we do blood glucose testing as feedback to see if somebody is able to match the carbohydrate and the insulin. And when we teach carb counting, we teach 3 things. What are carbohydrate foods? I like to start with that because many people know what carbohydrate foods are, so that they already know something, which is starting off on a good foot, knowing something. And then how much is one choice and how many choices to have at each meal and snack. So with that as a review, let's move on to today's topic, and that is the ADA nutrition recommendations. There are 4, and I'm going to be highlighting them. They deal with eating patterns, enjoying food, individual needs, tools, and resources. So with that, let's have our first polling question, and you will need to respond to this. The question is, the American Diabetes Association nutrition recommendations highlight the value of a Mediterranean-style diet, the need to eat low glycemic index foods, and the importance of a low-fat diet, less than 30% of total calories. So is it one, or is it all of the above? And I see the responses are coming in, fast and furious. Thank you for responding. And Oh, still coming in. There's lots of you. Slowing down just a bit. So I'm going to close the poll and go to the results. And what we have is 11% saying the value of a Mediterranean style diet. About 8% say the need to eat low glycemic index foods, and the importance of a low-fat diet, about 7%. And then all of the above was 74%. So I think many of you will be surprised that the correct answer is actually A, the value of a Mediterranean style diet. Now I'm going to quickly review the responses just to be sure that I highlight this, because so many chose all of the above. We'll get into the Mediterranean style diet, but the need to eat a low glycemic index foods, the ADA recommendations highlight that there may be value in eating lower glycemic index foods for postprandial glucose response, but it is not a strong advocate that everybody needs to do this. It's another layer of education. There's a lot of education that needs to go on when somebody has diabetes, and sometimes layering that information is too much detail. It's certainly something that dietitians think about when they're looking at somebody's food patterns and their glucose response, but ADA does not say that everybody needs to be on a low glycemic index diet. And then the importance of a low-fat diet. Less than 30% of your calories from fat is a low-fat diet. And what we're actually seeing that if you choose the right fats, you can actually go up to a 40% fat intake and control your blood sugars, and it's good for cardiovascular health. So with that, let's move on to the next slide where I review goal number 1. And that is, there's 2 parts to goal 1. So this is the first part, and it's promoting and supporting healthful eating patterns, emphasizing a variety of nutrient-dense foods in appropriate portion sizes, specifically to address, and we call these the ABCs, glycemic control, and that's typically evaluated by an A1C test, which is a test over the past 2 to 3 months of how much glucose was in the blood pressure, and lipid goals. So lipid is the C. So A1C, blood pressure, and cholesterol for lipid goals. Achieve and maintain body weight goals. And they have in there maintain body weight. To lose weight, that really, the value of that is really in the pre-diabetes stage or the early type 2 diabetes stage. We want to ensure sometimes just maintaining current body weight is a terrific goal to set. And delay or prevent the complications of diabetes. So there's a lot going on. There's a lot that we can do with nutrition therapy. My next slide highlights the value of medical nutrition therapy on the A part. And this is really a lot of times when we're looking at the effective diabetes therapy, we're looking at the A1C, but we can't forget all those other aspects either. But I just want to highlight that the value of medical nutrition therapy is effective in lowering the A1C. For type 1 diabetes, it's up to 1%. For type 2 diabetes, it's up to 2%, and that's a dramatic decrease in A1C. And then what the ADA does, and other organizations, when they put out recommendations, you probably have seen this, that there's evidence and then it's rated. The ADA rates it as an A rating, which is very, very high research. It's randomized controlled trials that are done with a good number of people. B is they may be randomized controlled trial, but not the high numbers that an A rating would get, or it's really good research and they're not all randomized controlled trials. So A and B evidence is strong evidence. And so we have very strong evidence that the amount of carbohydrate and available insulin may be the most important factor affecting the glycemic response after eating. So as I said before, when you eat your carbohydrate foods, you need the right amount of insulin to bring that glucose down. And so that's where if you're working with food with somebody with diabetes, that's why we often test the blood sugar before and after to see how much their blood sugar goes up from before a meal to after a meal. We usually check your blood sugar 1 to 2 hours after. With gestational diabetes, we check it 1 hour after. We're just so much tighter with our glucose values. But type 2 especially, it's 1 to 2 hours after you eat, and we want to see the blood glucose coming back down. If it's not, then we look at the food and the amount of food that somebody's having, we look at their activity, and then we also look at if they're on any medications. So we can always adjust food, but it's not always the food problem. It could just be that the diabetes is progressing and the person now needs a different medication regimen, or they need a redistribution of their carbohydrates if they're able to do that. The second evidence that I want to highlight here is monitoring carb intake, whether by carbohydrate counting or experience-based estimation, remains a key strategy in achieving glucose control. So this next slide shows just the dramatic decrease in A1C, and as Jessica mentioned up front, that you will be able to access these slides, and you'll have a copy of this, and you'll have the reference if you want to use this in any of your work to highlight the importance of MNT. But you can see this was a study done in the UK. It was done with study participants who have type 2 diabetes. Its corollary is the DCCT trial, which was done with people with type 1 diabetes. And these were newly diagnosed people with diabetes. During the run-in period, they had 3 visits with the dietitian, and their A1C decreased by 2%, 1.9%, which is very dramatic. That's a dramatic decrease, shows the value of nutrition therapy. But you can see as both lines go up, one's the conventional group, one's the intensive group, diabetes is a progressive disease. So you can have the best eating pattern. Because your insulin changes over time, you need different medications. This next slide defines what I mean by monitoring carbohydrate intake. It means spacing the carbohydrate intake over the day. It's portion control, avoiding excess carbohydrate at any one meal, and you know if it's excessive by glucose testing. And so this is a guide that we use at the IDC, although I must say that we always do a food record. We find out how somebody eats. And just thinking of my day yesterday in clinic, I saw a woman from Vietnam, and I saw her with her husband and a Vietnamese interpreter. I had a woman who had gestational diabetes, another woman who had gestational diabetes who was Spanish speaking with a Spanish interpreter. She wrote her whole food record in Spanish, and so we had to interpret that and figure that out, and some of her glucose values were elevated, and we actually needed to start insulin. But my role was critically important in determining if we needed to start a medication or not, because I had to figure out what she was eating. I also had a patient who was from India yesterday. So we have to work with each individual's eating style, but it's actually controlling the carbohydrate, whatever their carbohydrate source is. This next slide is the part 2 for goal 1, and it's focusing on dietary patterns rather than individual nutrients. So even though we talk about carbohydrate, we are really looking at overall eating patterns, just like with the 3 people I saw yesterday. I'm looking at their eating patterns, but I'm also thinking of the nutrition quality. I saw a man who to me was fairly young. He was 64 years old, living alone, but he has memory loss, and we're trying to keep him stable by himself. He's taking some medication that can cause low blood sugar, so I'm working very carefully with him. His focus is having carbohydrate at each of his meals and his snacks. However, he's also, for lunch, he's having a bag of chips. For his afternoon snack, he's having a bag of chips. For dinner, he's having his bag of chips. And for his evening snack, he's having a bag of chips. So I'm definitely focusing on improving the overall healthfulness of his food choices. And so we wrote out some guidelines for him to work on, rather simple guidelines. It's step by step. And Constance is going to talk more about how we help people make these behavior changes. So the evidence, as noted here in this blue box, is that an eating plan emphasizing the elements of Mediterranean-style diet rich in monounsaturated fats may improve glucose metabolism and lower cardiovascular disease risk, and can be an effective alternative to a low-fat, high-carbohydrate diet. So goal 1 is food intake is a critical component of diabetes treatment. And this is just comparing the two food pyramids, and a couple things I just want to highlight about the Mediterranean food plan is that it's very low in red meat and also the processed meats. It's higher in the mono and polyunsaturated fats. This is where if you choose the healthier fats, it's not a negative to have a higher fat diet. Fat improves satiety and helps people from overeating. So sometimes if somebody is hungry, we'll suggest that they have a cheese stick or a little bit of nuts or peanut butter with their fruit, or a little peanut butter on a piece of toast for just the satiety effect, and not to dramatically increase the calories, but help them from eating excess calories at other meals or snacking. But also what's very important is the base of the Mediterranean style of eating. It includes daily physical activity, and what's not shown here is that it's also the social aspects of eating with others and enjoying the social aspect. So the next slide highlights the third. Let me see if I can get it. There we go. Goal 2 is maintaining the pleasure of eating by providing positive messages about food choices while limiting food choices only when indicated by scientific evidence. So we know that food is social. It's a sign of friendship and caring and love. It's important at holidays and other special days. So rather than saying do not eat, provide specifics about what to eat. Like the lady from Vietnam, her husband said the diet is rice, 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 and so 4 times a day she's having rice. And so we worked out how much rice. We had food models, we had measuring cups. I wrote in a pictorial book how much rice and at what time, and I think she understood. Her husband spoke English, but the interpreter was there to translate to her. We were able to have fruit for snacks, so she was getting the nutrition in, and also having some dairy. So, I'm certainly cognizant of eating patterns and trying to make it as helpful within the cultural aspects of somebody's typical eating. The summary of goal 2 is be positive talking about food. Food should be enjoyed. Moving on to goal 3, it's addressing the individual nutrition needs based on personal, cultural preferences, health literacy, numeracy, access to healthful food choices, willingness and ability to make behavioral changes. So there's not a standard diabetes meal plan. Each individual needs to understand their own, and as I've highlighted already, that we need to include foods that they're most accustomed to. The food plan should be easy to implement. So with creating a positive learning environment, I just want to focus on especially number 2, being patient-centered. This is something that we hear in healthcare these days, and being patient-centered means engaging the person with diabetes in decisions, ask questions to help understand the best first step, and individualize based on the medical, nutritional, educational, and psychosocial needs. So we really are taking a holistic approach looking at the individual. Here are 5 questions that you might want to consider asking if you are seeing somebody that has diabetes or working with them in a variety of capacities. You can ask open-ended questions such as how is diabetes affecting your daily life and that of your family, and see how they respond. How they respond is going to be where their issues are, and that may be the best place to start the conversation. And you can see the others, and they'll be on your handout. So when we're addressing individual needs, I'm going back to the blue and red boxes that I showed you at the beginning, but I filled in a few other points. The nutrition assessment, all of this needs to be addressed, and I've highlighted the stage of change, and Constance is going to address that more, but we have to know where the person is, what they know, what their abilities are, do they have access to food. You know, it does me no good as a dietitian to recommend a certain eating pattern and thinking I'm individualizing it if they don't have access. One patient that we had yesterday is pregnant and living in a homeless shelter. She gets 3 meals a day. They're served at set times, which is great, but we also want our women with GDM to have snacks. So we have to talk through how can she get snacks, what's something that's non-perishable that she can have at certain times. So it's working within each individual's constraints. And as you can see, under each of these red boxes, there's a lot that can be taught. And I want to highlight that there's cognitive overload. We have to be very aware that we don't overload somebody so they're more confused, they're more overwhelmed, they don't know where to start. So we have to use our expertise and our control as to what we address at each individual visit. It's a step-by-step process. The next slide is a polling question, and so it's selecting a diabetes food plan includes which of the following? Being aware of cognitive overload, assessing literacy and numeracy, asking open-ended questions, or all of the above? One of those or all of the above? And I see the responses flying in. Lots of responses. There's really a lot of you. And again, thank you all for joining us today. So I'm going to skip to the results here. We'll hit the magic there. Oh my gosh. Okay, I'm going to skip to the results. It looks like we certainly have a trend. And being aware of cognitive overload, which I just mentioned, we got about 1% there. And about 1% for assessing literacy and numeracy. And about 4% for asking open-ended questions. And 94% with all of the above. And it is all of the above. We need to be aware of all of this when we're working with somebody with a food plan. If they cannot do numbers, then I'm not going to talk about them counting up carbohydrate grams. If they don't have a good health literacy, I'm going to be maybe use pictures and or shorter materials with them. But always asking open-ended questions and always being aware of cognitive overload. So wrapping up, I have just a couple more slides here. This next slide is Goal 4, and it says to provide the person with diabetes practical tools for day-to-day meal planning rather than focusing on individual macro, micronutrients, or single foods, but how do they plan their overall meal? But yet, you know, the person who I had yesterday who had rice, you know, I used the pictures, I wrote in the times, and I wrote in how much rice she was to have and highlighted that she could have her chicken and fish and her vegetables. Those weren't counting to the carbohydrate. It was really the rice that we were monitoring. So I had to provide the right intervention and support to get her going on her food plan. So it always has to be individualized. And we can use the plate method, we can use sample menus, we like to provide recipes that are pertinent to each person. So this next slide shows just some materials that can be used, even the USDA My Plate. It works for a lot of people. We don't always have to use fancy things. Starting out simple, letting the person ask more questions, and advancing as they're ready. And then just 2 more slides. This one is practical tools. And I have these in here to remind me to talk about, we talk to many of our people with diabetes about portion control and measuring. But we don't want people to take their measuring spoons and measuring cups to Aunt Betty's for Thanksgiving dinner or out to a restaurant. We want them to be good estimators of portion sizes. So I often work with somebody's palm of their hand and their fist, and how big is their fist? Is it half a cup? A cup up to their knuckles is a half a cup. If they cup their hand, how much is that? And so with each individual, we look at it, and I have my measuring cups, and I have my foods that are portioned, my food models that are portioned out, so I can actually teach estimation right there with them. And then just my wrap-up slide to highlight the 4 nutrition goals are 1, promoting a healthy eating pattern, 2, maintaining the pleasure of eating, 3, address individual nutrition needs, and 4, provide practical tools. And with that, hopefully we're getting somebody off to that first step. But I'm going to turn it over to Constance now, and she's going to give you some more insights to help get to that first step. Constance, over to you.
Thank you, Maggie and Jessica, and also thank you to the Bell Institute for sponsoring this webinar today. As you leave this webinar, you should be able to summarize 6 techniques of motivational interviewing to facilitate behavior change and also help individuals improve food choices. And then, of course, match behavior change strategies to an individual's readiness for change. Maggie's given us a lot of good information, education that she provides her patients, but unless that individual is ready to change, Maggie's just talking. She's just giving a lot of information. So it is important that we look at those strategies. So we're going to start off by discussing the stages of change. We'll go into motivational interviewing, and of course, if you have any inkling as to what motivational interviewing is, you know that can be a full day seminar in and of itself. So we're really just highlighting some of the strategies that can be used in terms of motivational interviewing. And then we're briefly going to look at the AADE7 self-care behaviors for the management of diabetes. Now, the stages of change model is used to assess an individual's awareness of the need to change and also, as I mentioned, their willingness to change. And according to the developers, change is not a single event, but it's actually a process. And that process involves 5 specific stages. We have pre-contemplation, the first stage, contemplation, preparation, action, and maintenance. And what the research shows is that we're able to get the best outcomes when we're actually able to match our intervention with that individual's readiness to make change. So here's our first poll question. And the question is, during an initial counseling session, in which of the stages of change is a new client most likely to be? Contemplation, action, maintenance, or termination? Okay, coming in fast and furious. Very good. Give it another second or two. Okay, we've got just about everyone participating. Excellent. Okay, so let's look at our results. And wow, we've got actually almost 90% that have selected contemplation. We have a small percentage, about 8% for action, 2% for maintenance, and no one, oh yeah, we do. We have 0.9% for termination. Okay, well the answer actually is contemplation, right? So most people that come in, that you're meeting for that initial session, they will be in contemplation and also pre-contemplation. So in terms of the poll, contemplation was the best answer, but you'll find many will be in pre-contemplation as well. So let's look at our first stage, which is pre-contemplation. And when we talk about pre-contemplation, this individual basically has no intention of making a change. And they may actually just tell you, I don't intend to make any changes in my eating behavior. I'm comfortable exactly where I am. And they may be unaware that they actually have a problem. You may hear them verbalize, something to the effect that what difference does it make? My whole family has diabetes. And at that point, you don't want to start teaching them how to count grams of carbohydrate because they're not ready for that. What you can do is provide them with some basic information in terms of the benefits of counting grams of carbohydrate. And so we really are at that stage trying to get the individual to consider that they may actually have a problem. So that's someone who is in pre-contemplation. Our second stage is contemplation. And in contemplation, as you all seem to be well aware, the majority of you, this person is coming in to see you, and they are actually, recognizing that they could benefit from making a change. They're beginning to evaluate, look at the, they're thinking about it, and your job is to help them to evaluate the pros and the cons of actually making that change. And we would expect this individual to make that change in the foreseeable future. So again, we want to raise their awareness of the problem and also help them to recognize what their current behavior is. And our third stage is preparation. And in preparation, the client is actually ready to begin to start making those changes, counting those grams of carbohydrate. They may actually be asking you for some help at that point. They may be asking for menus or recipes. If they're monitoring their blood glucose, they may be asking you to show them how to use a meter, how to use the lancing device. So again, in preparation, they're beginning to take small steps towards making that behavior change. And here we want to encourage that. We want to help them to move from that preparation stage into the action stage. So we want to help them set realistic goals. Oftentimes, our patients go from one extreme to the other, where they're doing absolutely nothing, and then all of a sudden they decide they need to make a change, and now they're going to cut all carbohydrate out of their diet. So we want to help them to set realistic goals. And then, of course, demonstration. You may need to show them how to actually count those grams of carbohydrate. And you may need to teach them skills. They may not know how to weigh and measure their food, how to make good guesstimates in terms of portions when they're eating out, as Maggie mentioned. So we want to help them, and we want to set them up so that they can go on and be successful in that action stage. And in action, here they've recently made that change. They've recently started counting their grams of carbohydrate. And if they're doing that consistently for at least 30 days, that's what we consider really being in that action stage. For the past 30 days, they've been actively engaged in counting their grams of carbohydrate, staying within their carbohydrate budget. And we want to continue to reinforce changes and support, give them the support and guidance that they need so that they can continue and go on into that maintenance stage. We want to help them to manage temptations. We know there are always temptations. There are unexpected events that may come up, so we want to help them prepare for that. They may need to change their environment. If they love cookies and they're bringing cookies in the house, ideally they would keep them out, but if they're bringing them in, at least maybe we can get them to put the cookies above eye level in the cabinet as opposed to at eye level, so it's the first thing they see when they open up the cabinet. So again, help them to manage temptations, and we're always constantly reinforcing the benefits because that's what's going to help to keep them motivated to stay into that action stage. And then our last stage is maintenance. And maintenance is they've been continuing to count those grams of carbohydrate over a 6-month period. And that would be considered maintenance, 6 months or longer. And again, we're just always anticipating, helping them to manage particular temptations that they experience or that we anticipate and help them remember the benefits. And then, of course, the goal, primary goal there is to prevent relapse, help with relapse prevention. That is our ultimate goal when they're in that maintenance stage. And then we do have relapse, and of course relapse isn't one of our stages of change, but it is something that most people will experience. And here the goal is to help them to put it in proper perspective, to recognize that it's something that is inevitable. It doesn't mean that all is lost because they're in that relapse, they've experienced relapse. We want to help them to look at the progress that they've made up into the point of relapse. I find food diaries are very helpful in terms of evaluating the relapse. And in terms of a food diary, I like to think of it as history. They've been keeping a food diary for a while, or even if they've stopped, if they maintained it, let's say 6 months ago for a month, they can look back at that food diary and see the progress, see how well they were counting those grams of carbohydrate, what they were doing at that particular point in time, and ideally go back to that and, again, reinforce that they were able to count those grams of carbohydrate previously. They will be able to get back on track and count those grams of carbohydrate again. This is a great tool that can help you as far as assessing where your patient is along the stages of change. You can give this to the patient. They can check which box actually applies to them, or you can design it so that you're asking the questions. Do you plan to make changes in your diabetes diet in the next 6 months? So either way, these questions will give you an idea of what stage of readiness your patient happens to be in. So the most important thing to remember here, as a reminder, as I mentioned at the poll, is that most of your patients are going to be in pre-contemplation or contemplation when they seek dietary counsel. And we want to be very careful not to assume that they're in a later stage, because if we do, we can end up overwhelming the patient, and then, of course, we get nothing at all. They're not going to do anything. So we can't simply make our patients change by telling them what to do or why they should do it. Typically, we get the opposite effect if that is our strategy. So we must empower our patients to make changes and help them to progress through the stages of change in an individualized manner. And when it comes to diabetes, motivational interviewing has actually become the accepted model because it provides client-centered counseling, as Maggie spoke about earlier, which is aimed at helping that individual make sustainable behavior changes. Now, motivational interviewing is a directed method for the client to actually convince themselves. That's what we want. We want them to convince themselves that they can benefit from making a change. We can't convince them. It's not going to last if we do. They need to convince themselves. And there are several skills and principles that are associated with motivational interviewing. So we have open-ended questions, expressing empathy, develop self-discrepancy, roll with resistance, ask permission, and support self-efficacy. Okay, so we have our next poll question, and this is: which of the following open-ended questions is useful in motivational interviewing? How are you today? What should we talk about today? How would this make life better? How often do you do that? So let's see what you think the correct answer is there. Okay. Coming in nice and fast. We'll give it another second or so. And it looks like we're betwixt in between. Okay, so for the sake of time, let's look at our results. And it looks as if the majority have picked how would this make life better, and that is actually the best answer. That is the correct answer in the open-ended question. If we say, how are you today, they can just simply say good or bad, and that's the end of the discussion. If we say, how would this make life better, you're going to allow them at that point to actually, and we can close the poll at this point. We'll kind of look at this as we go to the next slide. We're actually going to be looking at open-ended questions. But when we have that open-ended question, it actually allows that individual to tell their story, and it gives you a chance to listen for any indication of what their readiness for change might happen to be. Okay, we can close the poll at this point. Okay. All right, so ask open-ended questions. As I mentioned, that allows that individual to tell their story, and this is another example of an open-ended question. What is your reason for wanting to lose weight? So again, it allows them to express their thoughts and their feelings. And then we have express empathy, and we know empathy is the shortest form of human communication. And in terms of empathy, you're validating their feelings. You're letting them know that you truly understand how difficult it is for them to make this particular change. So open-ended questions and expressing empathy can definitely help as far as motivational interviewing, helping that person to change their behavior. And then, of course, develop discrepancy. Oftentimes, what that patient is doing is completely contrary to what their goals are. So we want to help them to see that. We want to explore that discrepancy between that behavior and what their ultimate goal is. Supporting self-efficacy. Here, you're going to actually help to increase their confidence, letting them know that they do have the ability to make those particular changes. Sometimes we may want to relate that to their career and what skills are needed for that particular career and show them. If they're an accountant, for an example, well, certainly they're going to have the skill as far as counting grams of carbohydrate and maybe doing carbohydrate to insulin ratio. So again, we just want to reinforce, help them to believe that there is that possibility for them to make that behavior change. And then rolling with resistance. Now, Maggie kind of rolls with resistance with her patient that enjoys the potato chips. She didn't tell him, no, you cannot have potato chips, but what she actually did was showed him how to have them throughout the day as opposed to eating a large bag at one time. So this is what we consider rolling with resistance. We don't want to oppose them. We don't want to argue with our patients. We simply want to help them to move through the stages of change, and sometimes it requires compromise. And then, of course, asking permission. We always ask permission, and the benefit in doing this is it allows you to address what's most important to your client at that particular time. If you, say for an example, you ask them, would you like to see this tool that I have in terms of mindful eating, and they say no, we've got to be prepared for that no answer as well. And then we'd ask them, well, what would you like to discuss today? And that will enable you to address what's most important to them. After you do that, then they may be open to discussing mindful eating. Okay, so the AADE7 self-care behaviors actually will help. They can be used along with motivational interviewing because they, too, encourage patients to become knowledgeable about their self-care. And there are the seven self-care behaviors. You can see them. We know diabetes is chronic disease, a daily disease, and it requires a lot for that person to think about. And the 7 self-care behaviors gives them a sense of direction and helps them with that, of course, with the aid of an educator to guide them through. So we're going to just look at healthy eating right now, and I'm just going to provide you some really practical strategies that you can use with your patients that will help as far as maintaining the pleasure in eating and getting the best outcomes. That's what we're after. So we'll go to number 1. They don't have to give up their favorite foods. Right, again, thinking in terms of Maggie's patient with rice. For an example, she loves rice. It's part of her culture. She doesn't have to give up rice, but Maggie showed her how to keep that rice within her carbohydrate allowance. You have a patient that loves to eat muffins for breakfast in the morning. We want to roll with resistance. We're not going to tell them, no, you can't have a muffin. You can still enjoy that muffin. We may give them a recipe for a healthier type muffin, the Morning Glory muffin as an example. And that reminds me, you can click and go to General Mills' website where they've got tons of recipes for healthy muffins. And that way you're rolling with resistance. The patient is more likely to follow through with the recommendation. Choose your carbs wisely. Maggie spoke about the Mediterranean style of eating. If they're following that type of meal plan, we know at the bottom it has couscous and polenta. These are all whole grains we want to introduce our patients to, make sure they understand how to read the whole grain label and look for the stamp, and that they're cognizant of what a serving size is as well. So it's not that they can't have carbohydrate. It's not that they can't have pasta. We want to help them to shift from refined to whole grain versions. And 3, make small, gradual changes. And in terms of blood glucose control, it's really important to understand that it's the portion that is more important than the frequency. They have rice, for an example, every single day in the proper portion, they're going to get a good outcome. If they say they only eat rice once weekly, but then they're having, 3 cups of rice at that eating event, they're going to run into problems in terms of blood glucose control. So patients oftentimes miss that. So we want to help them to recognize that it is the portion size that is more important than the frequency. And then last but certainly not least, we want to help them forget that all or nothing mentality. So often the patient has a dietary indiscretion, as I like to call it. Patients say they cheat. In my office, I tell them no one cheats. You had a dietary indiscretion. And so we want to talk about that. And I remind them that it is persistence that is important, not perfection. It's progress that's important, not perfection. So if they've gone off their carbohydrate budget 1 or 2 times during the week, I want to help them to look at that. There's 3 meals in a day, 7 days in a week, and 21 meals in a week. So if 1 or 2 meals are out of budget or they've gone off track, there are still 19 other meals that they maintain their carb budget. And you want to help them to see, well, what weighs more than the other. So always positive thoughts is what we want to leave them with, accentuating the positive. So final thoughts, it's important to remember that we get the best outcomes when we're able to tailor our approach based on the client's readiness to change, and that diabetes is a daily disease, and we want to empower patients or people with diabetes to make sustainable behavior change. So I'd like to thank you for your attention, and now we've got a few minutes for Q&A.
Thank you, Maggie and Constance, for your excellent presentations. We will now have the Q&A segment of our webinar. We've received many excellent questions during the presentation. If you'd still like to submit a question, you can use the chat feature located in the lower left-hand corner of your screen. If we don't get to your question in this webinar, we will post responses on our website. So the first question is for Maggie. What do you do when a patient wants to focus on sodium rather than carbohydrate?
Well, that's a really good question. And so remember, we're talking about meeting where the person is coming from. And one of my first slides had all the factors that we need to focus on with medical nutrition therapy, and one of them was hypertension or high blood pressure. And that certainly can lead to cardiovascular disease, and we know that the majority of people, over 75% of the people with diabetes, die of cardiovascular-related complications. So we certainly are interested in addressing sodium intake and blood pressure. So often when you reduce someone's sodium, if that's what they say they're most interested in, that's their priority, that creates a very healthy eating pattern. So it fits right in with the ADA nutrition recommendations of a healthful eating pattern. And so I would focus on that and hopefully work in some messages about carbohydrate distribution to be sure that it's a healthy eating plan. But I would more than likely focus on sodium if that's what they said their primary goal was at that initial visit. Absolutely. I want to set them up for success. Thank you for the question.
Thank you. The next question is for Constance. How can motivational interviewing be used in a hospital setting?
Thank you. Oftentimes, people feel that motivational interviewing can only be applied to a long-term care, someone that you're seeing on a long-term basis and that you have like 2 hours to sit down and talk to. But certainly, as you saw, we went through some of those strategies. Simply by expressing empathy is using motivational interviewing. Once you get that person to recognize that you do care and that you understand that it is difficult, you're going to have more success as opposed to if you never expressed empathy. And just asking open-ended questions, allowing them to share with you how they feel. So motivational interviewing can absolutely be used in the hospital setting. It can be initiated there. And, of course, the longer you have a relationship with someone, then you're able to use many of the other strategies that are associated with motivational interviewing.
Great. This next question is also for you, Constance. What type of approach should be used with a patient that has dementia or Alzheimer's and refuses to change their habits?
Well, that's a little difficult. That one is difficult because of the dementia and the Alzheimer's. So we've got to kind of work with their ability and what, again, they're still willing and able to do. They're going to require a lot more assistance than someone that has full mental capacity. So that really is, we can't expect the same outcome from that individual as we would from a healthy individual.
Thank you. And this is going to be our last question, and it's for Maggie. What are the recommendations for A1C in geriatrics? In my facility, the recommendations have been that for patients in their 70s, the goal should be 7. For patients in their 80s, the goal should be 8. And for in the 90s, it should be 9. Is this appropriate?
Oh, that's an interesting way to put it. I haven't heard that before. But typically, what the American Diabetes Association says in A1C, when we look at population health, 8% or less. But for the majority of the population, it's 7% or less. Now, when you're talking about somebody who's older, they can still attain the 7% or less, but sometimes we have modified goals and it's less than 8%. We don't typically go up to 9%. Even if somebody has a very complicated history, we're looking at less than 8%. The man that I saw yesterday who had some memory loss, he's only 64. He had modified glucose targets, so his target was less than 8%.
Great, thank you. And with that, we must wrap up today's webinar. As mentioned, you will be receiving an email shortly with links to the continuing education credits and slides presented today and a short survey. Last but not least, we invite you to visit bellinstitute.com and explore the website, which offers healthcare-specific nutrition resources. Today's presentation will be available on generalmillscf.com, where you can also find product information and great recipes. Thank you for your participation in today's webinar. This concludes today's program. You may now disconnect.